Hello and welcome to another edition of Professor Speaks. My name is Alex Hernandez. Alongside me, as always, is Dr. Craig Stern. And for our topic today, we're going to talk about preventable hospital readmissions and also expanding the role of the pharmacist. Um, this came up when we read about a study that's being done, and it's going to be published in the upcoming issue of the Journal of the American Pharmacists Association. This study found that about 26% of hospital readmissions could have been prevented, and we're going to go into a little bit more detail on that. And Dr. Stern, what kind of problems are these that are encountered in hospitals?
Yeah, I think this is a really topical issue. Aside from it being published, which is critically important,
Mm-hmm.
um, the issue has been well known for a while, and this further evaluates it and puts some peer-reviewed literature behind it.
Mm-hmm.
The issue here is the following: patients receive medications at home for ambulatory care. Then they go into the hospital. They receive medications in the hospital.
Mm-hmm.
They leave. Hopefully, there was some coordination between the drugs that they were getting as an outpatient and the drugs they were getting as an inpatient. By the way, that's a horrible assumption. Frequently, they're not well coordinated.
Right.
And then, because of problems, they go back into the hospital. Going back into the hospital frequently, the study that you're talking about deals with problems of compliance, and that may be compliance where the patient doesn't know how to take the drug, or maybe they've chosen not to take it the way that it was prescribed.
Which is when you mentioned coordinated also means not educating the patient.
That's correct.
Right.
Issues with regard to dosing too high or too low.
Mm-hmm.
That may have been a doctor-related issue. It may have been a patient-related issue where they think that they should take more if they're not feeling well or otherwise.
Right.
And then third are issues with regard to the coordination of the care so that there's no duplication of therapy that's going on
Right.
from what was prescribed in the hospital, what was prescribed at home, things like that. So that
Right.
goes on all the time. When I was in hospitals, constantly we were having to deal with these kind of issues.
Right. What kind of drugs are often related to these issues that come on?
Yeah, this would be easy if it was drugs that really didn't have a major impact. But in
Right.
fact, they're drugs that have huge impact.
Okay.
Drugs that are used for asthma or COPD are frequently a problem because people don't know the appropriate way to use their inhalers.
Right.
So they don't know how to use the inhaler. As a result of that, they're not controlled, and therefore they end up back in the emergency room or the hospital. Number two is that it frequently happens with drugs like insulin, where they don't know how to take the insulin, or they take too much or too little. Frequently, people can't see well, so they can't see the syringe well.
Wow.
And so they're not measuring out the right amount. Insulin becomes a major problem.
Mm-hmm.
So do pain medication, including opiates, where people are taking it, they took too much, or they took too little, wasn't clear how they were supposed to be taking them, and as a result, they ended up back in the hospital, either with more pain or because they have some addictive or some sort of dependence problems with that. And then there's additional problems with cardiovascular drugs, other respiratory drugs, some gastrointestinal drugs. They happen all the time because people take the medication. They are not aware of problems with regard to the dosing, adverse effects, what to do about it if they have a side effect, and how they're supposed to respond. This is very much of an education problem and things that people really need to pay attention to.
Right. And would you say that the amount of hospital readmissions, I'm assuming hospitals keep count of this kind of thing, but would you say a high number of hospital readmissions would reflect poorly on the quality of care that the hospital provides, or is it kind of like a
Well, the real problem here
right?
is, frankly, not pointing the finger at one person or another,
Okay.
because it's really a systemic problem.
Right.
So it's not like one guy messed up. It's about the fact that the process itself didn't work well.
Right.
And what has been instituted across systems, whether it's been done in managed care groups or not, is the fact that there hasn't been good coordination of a really good history when someone comes into the hospital with all the drugs they're on.
Okay.
A really good review of it in the hospital that will continue this, will delete this, will change the dose on this, whatever is the change. And then when they leave, which is the huge problem,
Mm-hmm.
is to coordinate to make sure that the drugs that they were on in the hospital, the drugs that they were on as an outpatient, are coordinated as to what they're going to be taking now.
Right.
And that coordination is huge. It's a systemic problem. It's not a physician problem, a hospital problem, a pharmacist problem, a nursing problem. It's everybody's problem.
Right.
And part of the issue in expanding the role of the pharmacist is we're looking at people who've spent at least 4 years in school and then additional time as interns or residents, like the interns and residents that come here to work with us.
Right.
And they need to be involved in the process because they know more about the drugs than does anyone else. So it's a relatively obvious step, but not one that people have spent a lot of time with. And that's where the real issue is.
Right. So when you mentioned pharmacists, we've already talked about the doctors and patients and their communication with each other. How does a pharmacist come in and help manage this problem?
I think the fundamental issue that we have to address is that healthcare today is a team approach.
Mm-hmm.
It's easy to say that there's a doctor and then everybody else kind of runs around it. But in reality, the doctor is really not just the doctor as a diagnostician, but also the doctor as the team leader.
Right.
The pharmacist is a respected, a significant part of that team. So is nursing, etc. In all of this, dietetics as well. But the pharmacist has the specific job of knowing who is admitted, getting an appropriate drug history,
Mm-hmm.
and knowing what the patient is receiving in the hospital. So there's a coordination between outpatient to inpatient.
Okay.
And then the pharmacist needs to know about who is being discharged so that they can then talk to the patient to make sure that there is a coordination of what was taken in the hospital and what is outside the hospital. It is trivial to think that everybody knows this, but it isn't.
Right.
In all the years I spent, I was constantly being informed about one person or another, but it doesn't happen all the time.
Mm-hmm.
And if anyone is in the hospital, frequently one of their complaints is, I didn't see anybody, so I didn't know. So this coordination, this communication
Mm-hmm.
has to work. And then whatever is seen, whatever is reviewed, needs to be distributed and communicated back to the rest of the team so that the doctor knows about it, the nurses know about it, etc. So it's not some big surprise when the patient goes home and no one knows what the patient is taking.
Right. And what we get from all of this is that communication between the hospitals to the pharmacists, or just hospitals to hospital pharmacists to community pharmacists, it's all part of helping a patient avoid these hospital readmissions for one, and any drug therapy that could be a problem for them, right? And
Absolutely.
yeah,
The people have often said to me, well, there's no financial motive here about this. And the reality of it is the financial motive is not the primary motivator. The
right,
real motivator here is to ensure that good clinical medicine is being done and that the right therapeutics are there. 26%, you're looking at a quarter of the people that go back to a hospital
right,
are back in the hospital because of medications. If you could prevent that, the cost savings is enormous.
yeah,
And the ability of these people to be able to determine their own world, work with their physician in an outpatient setting is significantly less expensive than what it would be in the hospital. So the cost issue is clearly there.
yeah,
The real issue, though, is the motivation of everybody wanting to ensure that the patient is kept well, that we've prevented whatever problems could have occurred,
right,
because prevention is really the name of the game here and really the key. If we can prevent it, then we have a chance of ensuring that, number one, the patient's life is not disturbed. They can lead a good life, they can lead a quality life, and that the that the cost and the use of hospital services is unnecessary.
Yeah, yeah. And that's all we really have for you today. And if you have any more questions, feel free to comment below. Do you have any else? Anything else?
No, I get that there's two things to think about. One is, what should the doctor do?
Right.
The doctor should always be aware and should always be asking, has a pharmacist seen this patient when they were admitted? Has a pharmacist seen the patient when they were discharged? Are we clear as to what the medication is? And then that doctor, if they're a hospitalist, needs to make sure that the physician is aware of what was done.
Mm-hmm.
And if they are the primary care physician for that patient, then they need to be aware, and they need to be aware of the sequence of what happened with the medications to have it.
Right.
What should the patient do? The patient should expect this. The patient should expect that they're going to see a pharmacist on admission, they're going to see a pharmacist on discharge, and if they're not, then they need to be asking the question, well, who is following my medications?
Mm-hmm.
Who knows what I was taking as an outpatient? Who knows what I was taking as an inpatient? Who knows what I'm taking again as an outpatient? So that there is coordination.
And who's looking out for my
And
well-being?
who's looking out for my well-being?
Yeah.
They should. I mean, it seems trivial, but it's
Right.
not. And the patient is part of the triad here of therapy: doctor, pharmacist, nurse, patient. And it is really incumbent on them to motivate the issue. I can't tell you how many times we've been called in to consult where we're consulting on something that should have been picked up, should have been addressed. And it wasn't because someone didn't try or otherwise. It was because the system just fell down and didn't look at what was going on. Frequently, there's problems with coordination of care. Someone is seeing a cardiologist, a gastroenterologist, perhaps a rheumatologist, and unfortunately, no one talks to each other, and as a result of that, one doesn't know what the other one is doing, and then the primary care physician doesn't know what's going on. Now, we can hope they do. I mean, God hope that everyone talks to each other and that it works, but there's way too many indications these
Right.
days where the system falls apart. And so doctors need to be asking, pharmacists need to be part of the team in dealing with this, and patients need to be demanding, well, where are these people? What's going on? So that I'm sure that somebody's covering it.
Sure, if you made a pie chart on how to prevent these fall downs in the systemic treating of a patient, I bet 90% of it would probably be communication.
Probably, probably.
Yeah. So communication is the key, and that's all we have for today. We will be off next week, and we're going to be skipping ahead in about a week, 2 weeks from today. Sorry. Sorry, M's like looking at me. All right, two weeks from today, we'll be back, and looking forward to our 50th episode coming up soon, so stay tuned. Please feel free to visit propharmaconsultants.com. We have a free information page. It's called RxInfoX. If you have a message for Dr. Stern, feel free to message us. Any other questions or comments, please leave it below, and we'll see you in 2 weeks.